going to look at the various challenges at the various levels of care. Once we treat you, then after 14 days, depending on the protocol, we discontinue you from the transmission-based precaution and we discharge you. And as you realize at the end of it, if we discharge you, we have what we call post-COVID. That's not the end of the story. Next slide. So who do we consider as sick? Most of our patients, fortunately, are asymptomatic, and that is what makes the disease very dangerous. You know, recently, Prof. Ampofu was telling us those who are supposed to be traveling and they need a PCR to travel. We are picking so many positive cases. And these are people who have traveled from Kumasi in a VIP bus, walks to Noguchi, goes to do the test, goes home, and waits for the results. And when the results come, imagine how all these people have encountered. And that is the major challenge with COVID. Most of our patients are asymptomatic. Another significant proportion also have mild disease, maybe loss of smell, loss of taste, headaches here and there. So these categories are mild ones. They have the moderate, they are worsening, they have pain, bad cough, and they may need oxygen. But when it comes to the severe critical, then we are in the danger zone. They have difficulty in breathing, they need oxygen support. And sometimes they need ventilator support and sometimes dialysis, especially those who have chronic renal disease. Now, how do we manage them? If you have those who are asymptomatic and mild disease, and fortunately for us, over 80–85% of our patients are in the asymptomatic and mild disease. So that makes it easier for us to manage. For those ones, we can manage at home, or what we call out of hospital care. With those ones, we need to assess you further, those with what we call comorbidities, the hypertension, the chronic renal disease, the diabetes. These we have to manage in hospital. And of course, if you have moderate, severe, or critical disease, we need to manage you in hospital, or what we call the treatment center. So let's look at the various care plans and some of the challenges that we have there. If you look at the patients that we manage at home, a lot of them don't adhere to the guidelines. You assess them, you tell them exactly what to do, they don't even stay at home. Even if they are staying at home, they are not using it. There are protocols for home care. Anybody who is doing home care, we assess the home facility and I tell exactly what you're supposed to do. But unfortunately, a lot of these patients don't follow the protocol. We've had instances where you are called that this patient that you saw, whose house you visited, is in the market walking around shopping. So not the adherence to care guidelines is one major challenge when it comes to managing these patients at home. Some of them even don't trust the results. It becomes very difficult for the psychosocial team to even able to tell them that the result is positive, for them to even accept to enter the care pathway. Sometimes they give us wrong information. Because when they are at home, you need to contact them via the phone. Sometimes they give you wrong phone numbers. You can't even reach them again. Some of them will give you wrong home addresses. Okay? And of course, we know about the stigma from community. We've all heard stories from various places, stigma. Where you go home, nobody is going to accept you. And it becomes a major challenge for healthcare givers to be able to get this to integrate. I remember when we started, we used to use ambulances to move these people around. People would not even accept taking them in the ambulance to their home. And then those who were positive and we had to move them from the communities, it was a major challenge. Ambulance is a no-go area. And we had to rely on national security to be able to move some of these people into isolation centers. And of course, once we discharge them from home care pathway, we need to disinfect the home environment. That also became a major challenge because some of them will not even allow you into their home environment. Previous slide. What about the health caregivers? What are the challenges?
So, Dr. Samba, can I just interrupt you at this point? I want to find out, you talk about the fact that people are not adhering to the home care guidelines. Is that, or does that mean that we'd have to revise the strategy as far as home care is concerned?
Yes, yeah. That's what Dr. Siansa was talking about. Based on these challenges, we devise other strategies when it comes to home care. Unavailability of logistics. You know, even transport to go to the home to do assessment. phone, credit to make calls, data to be able to track these people down was a challenge. And as he said, 25 vehicles have been released by the Flagstaff House who were able to go to these people's home. What happened was, initially, you assess these people, they are at home, you need to go and contact them minimum 3 visits. But with the increasing numbers, then logistics becomes a major challenge. Transport, credit, among other things. The other challenge that we have with home care is poor linkage between the district teams and regional teams. You know, you have people at home who is managing these patients, because each patient who is at home needs a clinician to be monitoring. But with the increasing numbers and unavailability of logistics, this became a major challenge. And to make matters worse, it was good for us because then we didn't need 2 negative results to discharge you from the care pathway. What clinicians and some providers were doing was that once you are diagnosed, they say stay home for 2 weeks. Whatever you are doing is not clear to them. After 2 weeks, they call you that you are discharged from the care pathway, which is a major setback when it comes to home care management. And strategies have been put in place to augment and improve upon that. The other challenge with home care was poor linkage between some of the private labs and care, just like we're talking about. You have people who walk into the private labs, pay and have the COVID test done. All you are told is that your test is positive. There is no proper linkage with caregivers. So that is where you have somebody walking into your consulting room and telling that, oh, I've done the COVID test and I'm positive. Can you imagine the number of people this person would have contacted all the way? So a lot has gone on. A new strategy, there's a linkage. Once your test is positive, you are linked with a caregiver, and that is supposed to improve upon home care. Of course, sometimes there's verbal abuse of staff. Of course, we are trained to manage those things, but sometimes it can be very physical. I remember at the beginning, we had some of these convicts who were at the police hospital. We had to bring them to Gais. These people were actually drew out knives. You know, these were Burkinabes that were at the police hospital cells and tested positive. So sometimes they can be very physical. Those are some of the challenges. Of course, demotivated staff. Fortunately, with the present directive, with the 50% and the continuous tax exemption, that has improved remarkably. Next slide. This slide, unfortunately, is a bit, this is just to show you how many treatment centers we have in the country, how many isolation centers, how many ICUs we have, among other things. Now, we have over 2,000 treatment centers across the country. We have about 30 isolation centers. But as Dr. Nsiasa mentioned, when the numbers started going down, most of these isolation centers have closed down, because a lot of them were hotels that were rented. If you come to Greater Accra, we had to use PCC, which belonged to the Pentecost Convention. They also want to use their center. We use Pram Pram, which has to go back to GFA for them to use. So a lot of the isolation centers have closed down, and that is why we are moving to Greater Accra. We are moving to Pantan, for example, to revive the Pantan Isolation Center and also the Dodowa Isolation Center. The idea is that, next slide, if you have patients who need isolation and cannot do home care, you take them to isolation centers. The challenge we had with isolation centers was that most of these patients were not sick, physical sickness. They were able to, if you go to PCC, they were able to move around. Some of them were even jogging, having fun in the morning, but just the fact that they were positive, we needed to isolate them to protect the community. Outrageous demands. They will tell you what they want to eat, whatever food you provide them, they don't even want to eat. You give them Baltic, they tell you that they want Belacqua. And then even sanitary pads for the ladies, they will tell you which brand they wanted. So these pose a lot of challenges. And if those travelers were very frustrated, they will not even go into the isolation center. And then the other challenge was transport. If the person came from Ashanti region, how to get the person back to Ashanti region. So transportation was a major challenge. But as Dr. Nsiasa mentioned, this has improved. Now, the other challenge we had, which we have surmounted, was delay in laboratory tests. That was a major challenge for the country earlier on in the pandemic. I mean, PCC, the idea was that we isolate you for a few days, we test you and negative, we discharge you. But the delay in the results meant that people were staying there 2 weeks, 3 weeks, sometimes even 4 weeks. And that was very difficult for a lot of the patients as well as care providers. And it was also very expensive for the state to be able to manage. Next slide. Now, when it comes to the in-hospital care, What are the challenges? Because once you are getting to the hospital, these patients are more sick, they are severe, they are critical. For the patients, a lot of depression, loneliness, fear of death. And you see, the thing about COVID is that you don't know how you, the individual, you are going to react to COVID. That is why you have very old people who get COVID and they recover. Nothing happens to them. You have a young person who gets COVID and then the person passes out. Sometimes that uncertainty creates a lot of depression, loneliness in the treatment centers. What about the caregivers? Dr. Nsiansari mentioned burnout. There's a lot of burnout. When we started, it was like within 3 months, COVID was going away. But here we are, we've done close to 9 months, COVID is still with us. A lot of staff, there's a burnout. So what do? We need to do a lot of training. We need to train as many staff as possible so that those who were in the front line, I mean, those were the courageous ones, because at the beginning of the pandemic, we had a lot of people who didn't even want to go to care given areas. So these are the people who volunteered, they are burnt out. Burnt out does not mean that they are stopping the work, but we need to appreciate what they've done, train more providers to take over from whatever they were doing. Of course, we have had over 3,000 healthcare providers who have tested positive, mortality about 14 across healthcare workers, which is unfortunate. If you have those who are working in the ICU, very stressful in the ICUs, and emotionally, the challenge we have is that we don't have a lot of people who are trained to do ICU care. And that is where we have a major challenge as a country. Of course, infrastructure and equipment is a challenge. Ventilators, supply, I mean, we got some ventilators, but some regions still need some ventilators. PPEs, at the beginning of the pandemic, everybody on the street knew what PPE, everybody was talking about PPE. But fortunately for us, the supply has improved significantly. That now, that worry or the fear that we don't have enough PPE, that's because now the borders are open, we are getting supplies from outside, the cost of PPEs has gone down, and of course, with the support from the fund, a lot of facilities have received PPEs. Oxygen supply is a major challenge in a lot of places when it comes to managing patients in the hospital. When we're doing our assessment, you go to certain regions and oxygen supply is even in Greater Accra, oxygen supply is a challenge. Next slide. As I said, for most of the patients, mild, symptomatic, moderate, I'm not too worried about them. One major concern is severe and critical, and that is where we are getting our mortalities from. Okay, the facilities available for care. I mean, Greater Accra, we are lucky. You know, because we have Kolebu, we have 37 is there, police hospital is there, we had Gais bed facility, board, we have a few private facilities that are for Greater Accra, we are not bad. Unfortunately, it's Greater Accra that we have the highest number of patients, and therefore the burden is so high. As I speak now, Kolebu IC is full, Rate IC is virtually full, UGMC is off, 37 has so many severe and critical patients. Gais Infectious Disease Center, as Dr. Nsiansari mentioned, is coming on board to support us to be able to manage severe and critical. And that is a severe and critical. Most of the resources should be going there. You see, the numbers that we are getting now are not frightening compared to before, but we are getting more ill patients, people with comorbid conditions. They are the ones that we are getting now. Gais Infectious Disease as soon as possible to take. You know, sometimes when I drive around, I'm good. I try to get space for very severe people. You see people walking around not wearing face masks, and then you ask yourself, where are we headed? If only they knew what I've seen just before coming to where they are. You know, sometimes people don't appreciate what is going on. We have limited beds and also facility for dialysis. We're getting quite a number of patients with renal disease, and once they get COVID, it takes them off, and we need to dialyze these people. So Kolebu is dialyzing. Basically, it's Kolebu 37. I'm not too sure. Police also is not doing that. So that puts a lot of burden on facilities. we did was to equip the hospitals to be able to manage severe. Um, they have ICUs with ventilators, but the challenge is the human capacity. COVID has really exposed us as a country when it comes to human capacity in managing severe and critical. We don't have the intensives. We don't have that good number of critical care nurses to be able to do that. But we are mobilizing them. We are mobilizing them. Unfortunately, we are able to mobilize to manage the ones that we need more. We need more critical care nurses to come on board. The teaching hospitals have done very well. Fortunately for us, the distribution of our teaching hospitals is not bad. We have Kolebu here, Konfanoche is in Kumasi, Tamale is up there, Ho, Volta region, and Cape Coast. So these are the burden, the critical care. 37 is here supporting, police hospital is here supporting. UGMC for now is off COVID. Okay, so Gais is coming. And that is where Ashanti region has a major challenge. Because when you talk about Ashanti region, it's only Konfanoche who is taking all the burden. Kumasi South is the original hospital, not well resourced. So what did we do? We got Professor Frimpong Boateng's facility at Twansi, where we refurbished the place and then supported to be able to manage severe and critical. So Ashanti region has a major challenge when it comes to managing severe and critical. But as I said, we need to train more, and which we are doing. We need to build capacity. And so now what we are even doing is train medical officers to be able to manage some of these patients in the ICUs. As I mentioned, oxygen delivery is a challenge. We've had WHO supplying some concentrators in some regions to be able to improve oxygen supply. COVID drinks oxygen. I mean, it's oxygen. Most of it is oxygen. And it's when we talk about patients in the ICU, we don't pay on ventilators. It's just that they need more monitoring. Later, then world. That's not just having a ventilator. You can have a ventilator, but if you the person who is trained to use the ventilator, it's even more dangerous than not having a ventilator. The facilities with the to be able to deliver. Because program, I mean, Bolga needs ventilators, Techima needs ventilators, Wenchi needs ventilators. That is our attention now, to be able to manage severe and critical. Because if you are able to reduce mortality rate significantly. Psychosocial issues. You know, the psychology comes to patient with COVID. Because even breaking the news, the numbers are low. And then Professor Ampofu showed me an article where he said 1 out of 5 are COVID patients have mental health issues. So mental health issues become very when it comes to post-COVID. Unfortunately, we don't have enough psychiatrists to be able to do that. The ICD unit of the Ghana said some nurses in the region to be able to provide psychosocial psychiatry. I talk about post-COVID. The thing about COVID is that for some people, once it's negative, you are stable and go. They tend to develop complications, fibrosis, very bad thrombosis, affects the kidney. So that is our attention. We need to look at the post-COVID. We are developing protocols and our trainings. We are telling people that set up some to be able to review these patients even after recovery from COVID, because that is becoming a major challenge when it comes to care. So the challenges are many. Of course, high cost of feeding of the patients. The staff, sometimes we have to feed the staff because they are there, they don't go out. So high cost of feeding, high oxygen consumption, I mentioned that. And because of the COVID, OPD attendances were low. And most healthcare facilities have to use their resources to purchase the PPE, the feeding of the patients, among other things. They are supposed to reimburse. The reimbursement process is a bit slow. This can be speeded up for the various healthcare facilities to deliver. All is not lost. management, despite all these challenges, we are working. The rate is so low, 0.66%, and is the best we can get in a lot of places, even though its mortality is not best, but we are working. We are saying that strict adherence, the COVID-19 safety protocols, is critical. It's key. Because, let's prevent it. Because you don't know how you are going to react. That is where I get scared. How the individual will respond to the virus, you can never predict. And therefore, the best thing is to avoid it. Let's use the safety protocol. Of course, proper coordination amongst us. What do we have in Greater Accra? We have what we call a dashboard. So if you have an ill patient anywhere, you put it on the dashboard, and then the clinicians will be moving the patients around to ensure that whichever facility has a free bed, or even you have to juggle the patients around to get a place to put that person for the person to receive intensive care is done. So linkage is very important. Linkage with the testing site is critical, so that anybody who tests positive is assessed and the care plan decided on. Adequate infrastructure, equipment with them. If you are going to do home care, we need a package, you need a pulse oximeter, you need a thermometer, you need all those things. We need those things to be able to deliver. Well-trained and motivated human resource. We just need to continue training to replace those who get burnt out, so that going forward, at any time we have enough human resource to be able to manage. Of course, timely provision of adequate and appropriate logistics, PPEs, oxygens, drugs, consumables in the ICU, among other things. And if you are able to do all this, then we say morbidity and mortality from COVID-19 will be averted significantly. Thank you very much.
Thank you, Dr. Samba. But two quick questions for you. You indicated the Infectious Diseases Center needs to be opened as quickly as possible. What's the challenge holding there?
The main challenge now is oxygen supply. It's just to connect the Infectious Disease Center to the plant, which they are doing now. So once that is sorted out, then we are good to go.
All right. And then, do we have cases of reinfections?
Reinfections in the country, I think Prof. Ampoku will be able to answer if you have speak any. What is happening, that's what I'm talking about, post-COVID. We need to be very careful. Once they've recovered, I don't know of any rare reinfection. Maybe Prof. Ampoku may have an answer to that. But you have it that people are having post-COVID syndrome. So they recover from COVID, and because of the complications that they've developed, they go to the healthcare facility and people think that they have COVID. But reinfection rate in Ghana, I'm not very much aware of any numbers. Maybe one or two, I'm not sure. Prof. Ampoku, or if you have.
Yeah, maybe what I'll add is that COVID is a novel disease, but we don't know very much about COVID. If people know very much about COVID, it's the Chinese. We are still learning. And the problem is that's the reason why we should do what we can do best to avoid having the COVID. Because we don't know what will happen in future. I know somebody who tested positive. The person is not a diabetic. He has never used insulin or anything before. As you speak now, he's on insulin. It attacked the pancreas. In fact, the virus attacks almost every soft tissue in the body, including the brain. So nobody knows. People who have COVID, and then after about 2 months, they develop urticaria, rashes, and they're having edema here. They see it turns into like it has a boil or something on the salt. So we should try as much as possible to do what is the easiest. The easiest thing is not to have COVID. And the easiest thing that you can do is to wear your mask. I know it's difficult to wear masks and walk around. As maybe some of us who are surgeons, we'll be wearing masks such a way that we even forget, and we drink our tea sometimes through the mask. So when you practice of it, you become used to it. So I'll just admonish everybody that if you don't want to have any problem, and if you have any problem in future, just put on your mask and put your mask properly where you're supposed to put the mask. And then use sanitizer, and wherever you find any running water and soap, wash your hands. Especially when you touch anything that you are not aware of. So that's the only thing that I would say. Because we don't know.
All right.
I've only heard about, I think, 2 cases where they have been reinfected. That they prove that yes, this is a reinfection. Now in Ghana, maybe Papa Popo, he tests all the patients, maybe he knows. But I don't know. It's a new disease.